Hello, everyone. Welcome and happy Wednesday. Thank you so much for joining us. Unfortunately, Dr. Wahab could not be here, so I'll be moderating today's event. I'm Dr. Tejas Mehta, a breast imager at UMass Memorial Medical Center in Worcester, Massachusetts, and co-chair of Society of Breast Imaging's Inclusion, Diversity, Equity Alliance. Tonight's webinar is brought to you by SBI and IDEA in recognition of Black History Month. The webinar is entitled Culturally Competent and Individualized Breast Care for the African American Patient. It is my great pleasure and honor to introduce our guest speaker for this evening, Dr. Karen Bankston. Inducted as a fellow in the American Academy of Nursing, Dr. Bankston is a professor emerita, a leadership consultant, and a former associate dean of the College of Nursing at University of Cincinnati. Also a fellow in the American College of Healthcare Executives, she's president and CEO of KDB and Associates Consulting Service, a company she founded after completing 5 years as Senior VP CEO of Drake Center Incorporated, part of Health Alliance, now also known as UC Health. Dr. Bankston previously served as Senior Vice President of External Affairs for the Health Alliance of Greater Cincinnati, responsible for local, state, and federal government relations, community relations, marketing, and public relations. She also briefly served as Executive Director of the Child Poverty Collaborative in Cincinnati. Earlier in her career, she held positions as Vice President of Operations and CEO and Vice President for Patient Care, Chief Nursing Officer at University Hospital in Cincinnati. Her past experiences include numerous nursing and nurse manager positions at the former Western Reserve Care System in Youngstown, Ohio. Dr. Bankston is known for her collaborating and engaging others for the benefit of changing culture, organizations, and communities to meet individual and group needs. So without further ado, thank you so much for joining us, Dr. Bankston.
Thank you. Thank you so much for the introduction. Sometimes when I hear all that, I realize how old I really am getting. I'm very excited to be with the audience today to talk about something that is near and dear to my heart, and that is about establishing collaborative relationships for the betterment of the individuals with whom we serve. This topic, while we've been talking for decades about the whole notion of the importance of cultural competency, still rings pretty strong in terms of a gap, in terms of being able to do it effectively. So I hope to spend just a few minutes just sharing a little bit of some of my ideas related to that and hopefully help others as they are looking to enhance their skill set. Now we're going to pray that I do this share screen thing correctly. And you all will let me know if I am there, because as I recall, I won't be able to see you. All right. Can you see that? Is it on presenting view? Can you all see it?
Yes, it looks great.
Okay. All right. So I titled this, It's All About the Relationships. Patient engagement. And what happened? Can you still see it? Hello?
No,
Okay.
no, it went away.
I did something. I hit something that I wasn't supposed to hit.
There we go.
Okay. Whew. Technology. Okay. I entitled it, It's All About Relationships, the Patient Engagement. And it is not letting me advance. Okay, hold on a minute. Okay. It's not letting me advance it. I can see it, but it's not.
Try the bottom arrow maybe.
The bottom.
Do you see the little arrows on the bottom?
Yeah, and it's not working on in that view. Okay, wait a minute, let's see. Hmm. Yeah, it's not working in that view. Let's start over again. Let's stop that. We're going to start over. There. Is it back?
We cannot see your screen. Oh,
No?
that's now it's back. Yeah.
It's back. Okay.
Yeah.
Very good. All right. I want to start with a quote. That'll help me to calm down. To reach others, we have to first know ourselves, and to contact the deeper truth of who we are, we must engage in some activity or practice that questions what we assume to be true about ourselves. I love this quote because I think that it really helps to lead out a discussion about why it is important for us to understand ourselves as we strive to understand others. So, the next part I want to talk about is culture, because I want to give a little bit of a background as to this whole notion of establishing relationships. So, these are just some things about culture we know and can perhaps agree that culture is the way we do business. It's the way we live our lives. It goes on every day, and it's not good or it's bad. It just is. And what we have to understand as individuals is that what may be considered just the way it is for each of us may be culturally influenced. And what do I mean by that? What I mean is that our lived experiences help us to shape who we are, what we believe, what our perceptions, assumptions, and expectations are. Subsequently, the more we know about ourselves and the more we know about others, the better the communication and the relationships that we have with one another can be. So, the way one does or sees things, when coupled with the way others do and see things, can lead to new and improved ways of doing and seeing things. When I think about the provision of care to individuals, when I think about helping individuals when they're in vulnerable periods of their life, I think about being able to understand it through their eyes, not just mine. And then recognizing and acknowledging that being different is okay. I would be remiss if I didn't say a little bit of something about bias, because a lot of what occurs sometimes as it relates to delivery of care is that individuals project their own biases on others or how they perceive others. So, this is just to help us be on the same page as it relates to how bias is defined, looking at it from the perspective of prejudice, being in favor of one or against others, and looking at being partial to others and so forth. So bias can sometimes get in the way. And that the lived experience of being on the other end of bias, oftentimes creates perceptions. And these perceptions are shaped throughout our life. They're the way that we talk, they're the way that we behave, it's the practices. And for Black Americans, and that's what I feel most comfortable talking about. For Black Americans, there are experiences and stories that have been passed down for generations, and those stories help to develop what it is that individuals perceive and believe. It becomes a part of the historical patterns of behavior that are in the way that we respond. At the same time, that's happening for everyone else as well. Everyone is living from their lived experience. Everyone is understanding from generations the kinds of things that have occurred in their life and the lives of their families. So when we put all of that together, what we begin to have are patterns of social and institutional learning that then are demonstrated in the behaviors that occur when people are meeting one-to-one or in groups. So why is this important? If you are familiar with the history of Black Americans, those who are descendants of slaves here in the United States, we know that there have been centuries of mistrust and mistreatment, and that mistrust has shown itself in the healthcare systems. In fact, healthcare for some Americans have been negated because of the biases and the prejudices that have existed over time. And because of that, there continues to be health disparities and a decline in health outcomes, particularly among Black Americans, because of a lack of trust. Black Americans are more likely than whites to say they don't trust their physicians or their nurses when we are looking at who it is that they trust. In an October 2020 poll, 7 of 10 Black Americans say that they were treated unfairly by the healthcare system, and 55% say that they distrust it. Subsequently, people don't go and get care. So when we think about health disparities and the health gap, we have to think about why are they not going. It's a combination of not trusting the individual providers because of those experiences and because of those stories that have been sent down for generations and decades, but also because there is a lack of trust in the organizations themselves. And as I share with my students, organizations are made up of people. So it gets back to the whole idea of everyone has their lived experiences. Everyone comes from a society that has its own culture, and all of those perceptions lead to the behaviors which, if without really being aware of it, create these negative outcomes that I know we're going to talk about in a little bit. Um, so we know that people who don't trust the healthcare system, and gosh, we're seeing a lot of that right now with the pandemic as we kind of wind that down. But people who mistrust the healthcare system and their organizations are much less likely to take medical advice or to keep follow-up appointments or even to fill any prescriptions, which then, of course, leads to these negative outcomes. So what do we do? What do we do? How do we begin to resolve it? We start by building the relationships. We start by first understanding why we believe what we believe, acknowledging the stuff that just is. Don't necessarily think about it as good or bad right now. It's just it is what it is. So let's understand that. And then we start by gaining entry into the lives of those we're trying to serve. We need to listen, actively listen, and acknowledge past mistakes made by people and institutions. They're factual, they happened. So let's understand it and understand how those that we are interacting with, how they feel about those past mistakes. So we need to listen with an open mind. We need to understand local experiences. Often when we talk about this whole notion of mistrust, particularly in the Black community, everyone brings up Tuskegee, right? So you remember what happened in Tuskegee, and that certainly was a horrible research situation. However, there are lots of communities who've also had experiences, and we need to understand as providers whether or not those that we are engaging with has some recall or have stories that have been told to them that occurred in their local environment, because that will play a significant role in the way that they behave and the way that they will interact with you. We have to increase comfort and a willingness to participate in a treatment plan. And how do we do that? We first need to get an establishment of alignment of values. This gets back to opening our minds and listening and getting a real sense of what it is the individuals and their families, what is that they believe in, what holds true for them, and then trying to get an alignment with that so that they could begin to understand things from a different light. This helps us in establishing trusting and equitable relationships. And how do we get to this whole idea of equity? Because we're talking about fairness when we talk about and equitable relationships. We're not necessarily talking about equality, but equity. And we do that by having some empathy. That is, taking that time, slowing down to not only listen, but listen with understanding and not get into arguments with the individual related to what it is that they believe, because they believe what they believe because of their own lived experiences. We have to understand that. And I say to people all the time, my truth is my truth. And it may not have ever happened to you, but it's my truth. And so we need to have some empathy as it relates to that. And then uncover instances of institutional racism. One of the things that I think is very true in today's environment, is that we don't necessarily have to have people who are, quote, racist, end quote, making decisions that are creating health disparities. We have over decades created policies and procedures that have created or led to racist racial outcomes, meaning that those rules or those policies negatively affect a certain group of individuals. And in this instance, we're talking about African Americans. But some of the things that are easy to understand or uncover are those related to access and affordability. I use as an example here in Cincinnati when COVID first uh, took off last year. One of the things that was interesting was that the decisions related to where they were placing the COVID testing sites were everywhere except in the urban core, which is where a significant number of African Americans live. So subsequently, we had a very disparate number of African Americans who were becoming positive with COVID. And so I was fortunate enough to work on with some activists here in town, and we spoke with several of the health systems that have hospitals or clinics in the urban core to say, how do we set up COVID testing sites where the people are so that they have access to getting tested so that we can begin to address the disparate number of individuals who were becoming positive with COVID. So I don't think that there was necessarily an intentional um, uh, idea from the people who are running those systems to not have COVID testing sites in the urban core. I think that they were utilizing their already set up sites, and those sites happen to not be in the urban core. And so bringing it to their attention and working collaboratively was able to make a difference. So we have to uncover those instances of institutional racism by looking at the information in the data and then making some different decisions. And then lastly, we need a welcoming environment. No matter where we are seeing our patients or our clients, people want to feel as though they belong. So we have to kind of get an understanding from them. This gets back to that listening and having an open mind of what it takes for them to feel welcome in the environment, because that, again, is the beginning of establishing relationships with the individuals. I just found this, and in a journal, excuse me, an article that I was reading, and while it was focused on mental health, I think the concept and the process is the same for everything. And what it says is that those previous racial, social, cultural experiences, so the lived experiences as I've been describing, lead to perceived discrimination, perceived mistrust, stereotyping and the use of unconscious bias, and cultural dissimilarity, that those perceived cultural dissimilarity. Because the fact is that sometimes, even when we have these perceptions, there's more similarity between the individuals than they know until such time they establish that relationship. At any rate, what this says is that those things lead to a healthy cultural paranoia. We just get a little bit paranoid about what's going on. So when the individuals come into the environment, they are automatically scanning. They're automatically looking around and making assumptions about things. And one or two roadmaps will occur. They will either feel uncomfortable with the provider, they begin to feel unsafe, they don't trust them, they feel ignored or misunderstood, and they feel disrespected. When that happens, you have a poor encounter. And then the likelihood of our being able to get the kind of outcomes that we want for everyone are highly unlikely. On the other hand, the other journey is we work to open our minds and begin to feel comfortable with the provider. They begin to feel safe and begin to talk about those things that are personal to them. This is when we get to understand their values. They begin to establish a sense of trust because now they're being listened to and they're being understood and they're feeling respected by the provider because that provider is practicing with empathy. When that happens, we have a good encounter. So we're on a journey. We're on this journey together. It's a little beyond the whole idea of cultural competency because a lot of times we talk about we need our providers to be culturally competent, and that is indeed true. But that competency is through mutual respect and understanding. It's understanding that each party brings with them their lived experiences, and that together, in understanding that and having empathy towards one another, we are able to start a process that helps us to minimize some of the negative outcomes and the health disparities that exist in our communities. So thank you for listening. I'm going to stop sharing, and I look forward to having dialogue with you all later on in our session.
Thank you so much, Dr. Bankston, for sharing your thoughts and insight. I'm going to ask that we hold some questions. We do have some questions, but we'll save them till the end. It gives me great pleasure now to introduce our second speaker for this evening, Dr. Tatiani Jackson. Dr. Jackson is a double-boarded breast imaging and nuclear medicine associate radiologist at Geisinger, Wyoming Valley in Pennsylvania. She's also a dear friend and colleague and co-chair with me on the Inclusion, Diversity, Equity Alliance for SBI. Dr. Jackson's passions are promoting diversity and inclusion across the field of medicine, particularly in the areas of equitable healthcare and research in marginalized populations. These passions stem from witnessing lack of diversity in medicine and the impact of health inequity and healthcare disparities on marginalized populations, particularly as we're talking about tonight in the AfricanAmerican women with breast cancer. So thank you so much for Dr. Jackson. And without further ado.
Thank you. Thank you for that introduction. Let me also share my slides. Can you see everything?
Looks like we see both it looks like we're seeing both screens. So one of the screens that has the,
let's see. Give me 1 second. Looks like it just closed.
Perfect.
Okay, perfect. So on this portion of the conversation, I'm just going to go over some situations where we can try to be a bit more culturally sensitive to our African American women and male patients who are coming in to get their mammograms. And I'm also going to briefly go through some of the individualized care when it comes to screening of this particular population. So I'd just like to start off with a question, and obviously this is something that's very important and near to dear to me, and it's the focus of this conversation, is essentially, why are African American women at high risk of dying from breast cancer? So many studies have shown that white and African American women have the same high incidence of breast cancer, but about 19% of African American women are more likely to die. And this is coming from data from the American College of Radiology, while the American Cancer Society has data that says about 39% of African American women will die from breast cancer. So why is this happening, and why is it still happening now in 2023? So I'm sorry, 2022. I'm jumping a year. So many say that is access, right? So it's access to digital mammogram and tomosynthesis. There could be disparities in healthcare delivery patterns that these patients are experiencing. Tumor biology is different, and then there are social economic barriers. So when we look at the underscreened breast cancer patients, it says that some data has shown that the disparities in screening across both white and African American women has narrowed, but there still remains a small subpopulation of underscreened African American women, and that many of these causes are mainly because these women aren't insured, which obviously is lack of access. Many women have insurance, but then they don't have a primary care provider, and that could be because of, similar to what Dr. Bankston stated, is that this lack of trust in the healthcare system, so they're not even eager to go out and seek a primary care provider, or just socioeconomic status, which can be anything from financial to logistical barriers when it comes to transportation and childcare. Other cultural attitudes that stem from causing these patients to be underscreened is just fear of breast cancer and a fatalism of breast cancer, that there's this doom that, when you get diagnosed with breast cancer, the only outcome is death. And then in addition, we have the patient experience. And if you have a poor experience in a healthcare system and it has nothing, it can be something separate from getting a mammogram, something as small as getting your blood drawn or just walking into a facility, that poor experience is going to perpetuate within a vicious cycle of, stopping you from going to continue to get your screening, which will help us find smaller cancers that are treatable. So in this next section, I'm just going to review some examples, and it's from this well-written research paper called Fear, Fatalism, and Breast Cancer Screening in Low-Income African American Women, the role of clinicians in healthcare system. So these examples are coming directly from patients verbatim. So I'm just going to read through it and then provide my suggestions of what are better ways to approach certain situations. So this first example is of a woman that went to get her mammogram. So the patient says, but the thing that I don't feel comfortable about is when you go to get a mammogram, the doctor tells you to sit down, a bunch of doctors come over and they check your mammogram, and then they make you wait, and then they come and say, oh, that's nothing. You've been waiting for a half an hour for them to come and tell you that it's nothing. I mean, I don't know who they think they can fool, but they don't fool me, that's for sure. You see, when I'm here left alone, I'm by myself with nobody with me. So this patient, from how it's interpreted, is that she went to get a mammogram. This could have been a diagnostic. The patient was told to wait. And then we go and we do our thing. We look at the images and then say, oh, it's nothing, you can go. But no one explains anything to the patient. So she's left feeling alone and unsure and uncomfortable in this situation. So the best approach for this, or how I would approach it, is one, in all my slides, the number one is to be an active listener. Listen to the patient. And when you're doing any kind of imaging on a patient and they're waiting for a long time, the best step is to go and talk to them personally and say, explain to them why they were waiting, explain to them what you see, in a, in a way that they understand. And the African American population and race is very diverse and is very dynamic, so you can talk to us or talk to any patient as you would talk to a friend. So you explain to them what you see and what you think it is. You reassure them and you just provide empathy and listen. Maybe, they're fine with your understanding and they understand that it's nothing, but, they were just scared that they had to wait, and maybe they just want to talk that out with you. And then after you've discussed the plan and you've told them what you've seen and what you think the next steps are, make sure that they understand the plan, ask them if they're okay with it, and do they agree? And most of the time, they're always going to agree. Most people will agree once you've pretty much laid out what you think the next best steps are. But this process will make them feel like they have autonomy over their care. They feel included and they feel educated. And with all that information, they feel empowered and they feel comfortable with the plan, with you, and they are more likely to come back to repeat or get more imaging next year for their next screening mammogram. This next example is in regards to poor communication. So this particular patient states that it took me to make a complaint about a doctor who took care of me to be treated better right at the hospital. It's not necessary. Why do I have to jeopardize somebody's job for me to be treated right? I'm a human being. I'm not a dog. Even dogs get treated better than us. Do you think these people would take extra care during a mammogram? They don't care about your pain. So obviously this case, it sounds like someone getting a mammogram, the compression, which, we've experienced, it's discomforting. But I think obviously listen to the patient. If the patient's telling you she's in pain, the patient's in pain, maybe try a gentle compression or just try to talk them through it. I would just make sure that you're clearly explaining what's going to happen and what to expect. Reassure them that the exam is fast. So even though it's painful, it's only for a couple of minutes and then you're done. And then we won't have to see you for a year unless you have to come back. But at least they know it's only a few seconds and we're almost finished. And always explain the next steps. And again, I think providing this additional information, again, will make the patient feel like they've been empowered, they've been informed, and they've been educated so that they know what's happening. And, these images are being taken for a particular reason. This is why we have to do the exam this way. I understand that it's uncomfortable. I can try a different technique. Please let me know how this feels. Is this better? But just engaging in conversation and educating the patient each step so that they know what's going on. And then they feel better because they feel like they're in control of what's happening. These next couple of examples are just looking at spirituality, and then there's some other examples with fatalism. So this particular patient, when it comes to religion and spirituality, just said, so I don't worry about breast cancer screening because only God can decide when it's time to go. Everything depends on how much faith you have. I know I could die tomorrow, so I don't worry about breast cancer. This next example is about fatalism, just death from breast cancer. So this particular patient said that I just thought you died if you had breast cancer. If you had breast cancer, you was going to die anyway. I don't know that I was the only. I didn't know that it was another possibility to live after you had breast cancer or had been found having breast cancer. Everybody I know who had breast cancer has died. I wasn't aware of anything different. So I think this is a big point of this conversation, is that we need to reach out to these patients and actively engage them, actively inform them of the importance of getting your screening mammogram, the importance of getting your blood sugar checked, the importance of getting your blood pressure checked, the importance of having these screening modalities or anything done yearly to make sure that you're okay, because everything is treatable. And the most important thing to get this point across to the patients and to this population is through community outreach, going to churches, going to community centers, having a survivorship program, Black women that have survived breast cancer, having them be involved. These women would gladly volunteer to educate and to help show that you can have breast cancer, you can live, it's treatable, and you can have a fulfilling life. Another thing that would be important is maybe having outreach with like a mobile mammal unit, where if these patients can't get to you via transportation issues or childcare issues, that they can go to their local community center and get a mammogram performed. This also helps build trust. If they see you out in a community and you're reaching out and educating and informing them and listening to them and listening to their horror stories or stories from other friends that was told to them, which is causing them to have more apprehension, they'll start to trust and they will follow up with the recommendation. And this also goes down the line with trust and education and reinsurance. So if you educate and you reassure someone, they will trust you more. If you show empathy and you listen, they will trust you more. And hopefully all this in return can come back with more outreach and getting them to follow with their mammogram. So this last example is just in regards to relationship and financial impact. So this one woman said that her husband rejected her when she had her breast removed, and she really went through extra trauma because of that. If I had to have my breast removed and my husband will still be living with me, it would cause me to have concern. The first thing that comes to mind is, oh, he's going to get another woman now. I'm no longer attractive. So I think this sentiment isn't only seen in Black women, but I think in many other women, especially the Hispanic and Latin population, where they feel like this treatment is going to disfigure them and that they're no longer going to be desired. Another sentiment is the sense of abandonment. And this is really important in people in low-income family, where if they lose a spouse, their financial and caregiving obligations intensifies, making it even harder for them to take care of themselves and their children. And I think all of these are just causes this intersectionality of perpetuating system where everything leads to poor health outcomes, negative care experiences, fear of healthcare system, psychological issues, and all ends up resulting in delay in seeking healthcare. So I think with a strong social worker network system, having many people in the system that look like us, having physicians that look like us that can help these patients. And in addition, the other physicians, just as Dr. Bankston said, go off your experiences and just know that each of us are the same person when it comes to being afraid. And we just need that outreach. We just need that hand holding and education, which to break down the barriers of distrust. So now when you're looking at it on the clinical aspect in regards to tumor biology, there's been many studies that have shown that African-American women are at greater risk of being diagnosed with triple negative breast cancer. And they're even at greater risk of having this type of cancer at a more advanced stage. There's been studies that have been conducted that shows that African-American women have a slightly higher incidence of BRCA1 and BRCA2 gene mutation. BRCA1 is at 10.2% versus 5.7% when you're comparing this to the Western European ancestry, which is at 6.9 and 5.2%. Also, what's important is that many African-American women are diagnosed with late stage breast cancer, which goes back to all the examples that we previously reviewed, where there is a cultural bias, they are uncomfortable, they are afraid, and there's a huge distrust in the healthcare system. A study conducted from SER data between the year of 2010 and 2015, looking at over 23,000 women, showed that these women were diagnosed with stage 1 through 2 breast cancer, that over 6,000 of these women were African-American, 17,000 of these women were white. And in the African-American women, when comparing them to the white women, the women were diagnosed with breast cancer at a younger age. They were most likely to be uninsured or insured through Medicare at 20.6%. And they're more likely to live in areas of low income housing. So that's at 14% versus 7% when you're comparing it to white women. Additionally, when you're looking at triple negative breast cancer in African-American women, we are more likely to be diagnosed with stage 3 breast cancer, have larger cancers greater than 5 centimeters, and have lymph node spread at time of diagnosis nearing 40%. And when it comes to treatments received for triple negative breast cancer, overall, between African American and Black women, 94.7% of these women had surgery, 75% had chemotherapy, and 51.9% had radiation. But if you're just comparing the African American women and pulling them out of the population and comparing them directly to white women, 31% of Black women were less likely to have surgery, and 11% of them were less likely to have chemotherapy. And I've read multiple studies where they say that some of these outcomes and these instances come from biases in the healthcare system, where they think the patient is non-compliant. Really, it's just the patient's non-compliant and non-reliable, but they're not looking at the bigger picture, where it's like, if these women are coming from low-income families, they probably have a shift job or something where they can't afford to take time off, because if they take time off, they're not going to be paid. And if you're not going to get paid and you have children, there's no food on the table and you can't pay your rent, you can't pay your utilities. Or the latter, if you're at home, you don't have childcare. So how are you going to be able to commute back and forth for chemo? Or how are you going to survive without assistance after you have surgery? So again, this goes back to the bigger picture, where this has to be a more holistic approach, where you have everyone involved, including social work, where they can provide and help find services for these women so they can successfully achieve response to the therapy, and they can have surgery and not think that having breast cancer is a death sentence. Now, when it comes to just screening, many organizations, such as obviously the ACR and American Cancer Society and the Breast Surgeon Society, they're all starting to recommend that these women have risk assessments, or all women, but they're mainly harping on African American women, that they should start having risk assessments for breast cancer between the ages of 25 and 30. And there's a ton of different modalities that can achieve this, but the most common is the Klaus, Tyracruzic, and BRCA Pro. Also, it's important to ask these women about their family history, first and second degree family history. If they don't know, at least starting the conversation is important. So then that makes them curious. And then you start to ask questions to your family. You can get as much information as possible. Genetic counseling is extremely important. And a high-risk breast clinic, which is also very important, because this will allow them to have access to a high-risk breast clinic counselor. They'll be followed, so it kind of removes the burden from the primary care physician, who may or may not be equipped to handle these kind of cases and to manage this kind of follow-up. Now, with all that being done and said, if the patient is found to be high risk for breast cancer, they should start getting their breast MRIs at 25 and start getting mammograms at age 30. Now, if you're in a community where breast MRI is just not accessible, or you don't have access, then obviously you can supplement that with whole breast ultrasound. But I think, everyone would say that contrast enhanced breast MRIs are probably a better option. And again, I already mentioned this, but I'll just repeat it. Mammograms should begin at age 30 if they're less than 40 years old and they're high risk. Now, if they have no high risk factors, then screening mammograms can begin at 40. And this is something that should be done on an annual basis. These are my references where I pulled the data from. Thank you for your attention.
Thank you so much, Dr. Jackson and Dr. Bankston, for sharing your thoughts and being here tonight. So I had a question or a comment for Dr. Bankston, my personal experience, right? Because this is my truth. I find quite frequently, particularly for certain patient populations, including African-American women who appropriately, historically lack trust, that it's worth sort of taking a few minutes and just acknowledging that as you walk in the room, sort of getting a story, you're nervous, how are you doing today? Or is there anything that I can do to make you more comfortable? And I think sometimes we forget that. We're so rushed, right? We're trying to see patient after patient after patient. But I think, taking that extra minute. I find personally with COVID, I'm a very touchy-feely person, and not being able to, sort of do as much physical contact is hard for me. Any comments or thoughts?
Yes, I'm glad that you said that. Dr. Jackson and I did not collaborate on our presentations. And as she was talking, I'm like, oh my goodness, she's just saying the same thing. This is great. I love affirmation. But I think that you're absolutely correct. Here's another piece of that notion of taking the time to get to know the person. Why that becomes important, even when we're talking about African American women, if you will, as a group, and that is we're not a monolithic group of women either, and depending on the part of the country, whether or not the individual is black because they are descendants of slaves, or they're black because they are immigrants from the continent of Africa, we have to understand that, and we won't understand it if we don't take the time to stop and listen. And I like that Dr. Jackson had that like at the beginning of each of her points of resolution. So the first thing is to be an active listener. And that's not easy. It's not easy. It's easy to hear, but it's not easy to listen and to really pay attention to not only what the person is verbalizing, but what's their body saying. What body language, and what message are they sending. I was a CEO of a hospital, and I know that we push physicians a lot to see the patient 15 minutes, return visit 15 minutes, and all those kinds of things. But I think it would serve us all better in terms of being able to reduce these disparities if we take that time, that moment, that small moment, to ask the question if the person is all right, and if there's anything that they want to share before we even share as providers. Is there anything they want us to know about what they believe? I mean, Dr. Jackson has given a lot of examples, real life examples of things that happen every day. And I was shaking my head because I'm like, yeah, I know someone who said that. I know someone, it's those kinds of things, and taking the time to really just understand. And we cannot minimize the impact of the social determinants of health, the things that she talked about, transportation, childcare, all of those things, what neighborhood they live in, all of those things play a significant role in the woman, or men, in their ability to begin to establish trust and want to carry out with the treatment plan. All of those things play a role.
Particularly the tardiness if they're late for their appointment.
Yes.
Again, a lot of places have rules. If they're 20 minutes late or 30 minutes late,
Yes.
whatever it is, we're not going to see them. And I always, advise the front desk staff who's turning them away to say, ask them why they were late.
That's right. That's exactly right.
And it's really enlightening.
If there are, when I was still working, I'm retired now. When I was still working, we had individuals who would be late for work. Some of our entry level frontline associates would be late for work, and we would have this revolving door of people getting terminated. And what we found out, and this is similar for our patients, because we had high no-show rates. We had high no-show rates in our clinics. And what we learned when we looked at the data, that's why looking at data also becomes very important, is how many of those individuals rode the bus, used the bus system. They didn't have a car. They used the bus system. And if they were coming from one side of town to the other side of town, they may have to take 2 or 3 buses transfer before they get there. So they're not driving the bus. They're at the whim of the system. And so asking the question and getting more clarity as to some reasoning. These are people that don't care about themselves. I know that that's a perception that people have. If you're poor, you don't care about anything. If you're lazy, and all these other stereotypes and negative things that people say, and not acknowledging that there are certain circumstances and barriers that are in our society that get in the way of people being able to do those kinds of things. And so just asking the question, taking out that time, that small amount of time to find out, gather a piece of data to help make a difference in the lives of someone.
And I think what's also important is that in breast imaging, when we do our diagnostics and when we do our biopsies, we see the patient. And I feel like we're almost like therapists in a way, because as
Yes.
soon as you walk in that room, they're already anxious and they're waiting for that good news. But you can always sense when something's not right. And there's been many instances where I could tell, like, did you just have difficulty getting here? Is it a transportation issue? And I'll always ask the patient, because it'll
Yes.
be a little late, and I'll just say, well, how'd you get here? Did you have to take an Uber? And then when they tell me, like, they took a Lyft or they had to take a bus or find a taxi, like, I quickly try to reach out to social work. So that's why, I think it's important for us as breast imagers to at least know who the social worker is for the surgical team, because they're very resourceful. And I always try to at least say, well, maybe I can try to arrange transportation for you next time. And I'll send an email and say, can you look into this patient's chart and see if they have a car, where do they live? I've had some patients where I was concerned about food insecurity. Like, I would do a biopsy and then they'd faint. And then I'd say, did you eat anything? And they're like, oh, we never eat breakfast. Like, that's just not right.
Oh,
And then you just kind of have to be keen and just pay attention to your gut, because sometimes
yes.
it tells you something's not right. Um,
Yes.
and most of the time you're right. And then if you have social work get involved and they're like, oh, I saw that this patient has this as a pattern, they like to help them with resources. I've had several instances since I've been at Geisinger, and I've been working closely with social work to help these patients, to even try to find a Spanish speaking social worker to help with some of the patients when it comes to dealing with their breast cancer diagnosis. Because I think I even asked the patient, and they said, frankly, like, they're uncomfortable using the translating system with the person on the audio, like on the iPad, because it feels cold and it's impersonal, and then they don't really ask all the questions, and they always left with questions, and I'm like, I don't understand, like, so then when I sat down and spoke with them, because I speak Spanish, I got so much more information. But when they did it with the surgeon got less information. So I think really it's very important to at least, go with your gut, talk to the patient, and if something doesn't seem right, you have their chart there. It's documented. You can definitely help assist them, because they're at your door, and when they're with you, this is the opportunity.
I think your description of having that collaborative approach to the care delivery is so right on and so necessary, and for so many reasons, because we can't all do it by each individual provider can't do it by themselves. We need the assistance of others who have different skill sets. I recently had my screening mammogram, and I received a call that they saw something in my lymph nodes. Now, I know enough to know that, oh my goodness. So my brain, I'm on the internet, I'm looking things up. I'm like, oh my goodness. But at any rate, when they called me back in to do that next step to find out what was going on, and then on both sides and all this kind of thing, ends up that they were just swollen lymph nodes. So nothing came of it. But what I appreciated was the breast imaging radiologist who sat down with me
Mm.
to explain what it was that was going on. And I don't often do this, but I did say, I'm a nurse. I just need you to talk regular. Don't just talk.
Yeah.
And I want to say that this physician was so kind, was so kind, and that made a great big bit of difference to me, for me, who knows a little bit too much. Sometimes too much that gets you in trouble. So I would agree with you that sitting down, taking that time, and just being open to understanding whatever the concerns are that the individual has will make a big difference. And, there are so many, I know a lot of women. I have several friends who've had breast cancer and they're still alive and doing well. But I know in speaking with them, when each of them got diagnosed, how afraid they were that they were just going to die. That was the end, that they were just going to die. And so, the therapy and the treatment has come so far. It's come so far. And I think the more that we're able to help one another in understanding the importance of this, listening and utilizing our intuitive knowing that we do have, and that is usually correct, that the better off it will be for so many people.
I think the other big point, at least that I wanted to make sure our listeners took home, is that the cancer, when it occurs in African American women, is more advanced. They're appropriately, should be scared until they don't have a reason to be scared. And at least where I am, quite frequently the PCPs are doing task force guidelines. And so it's almost a cookie cutter, start at 50, or even if those that start at 40 and every other year. But I really think for certain patient populations that have the aggressive cancers, important to take the time, as Dr. Jackson was talking about, to pause and say, should this woman start earlier, African American or not, but we're talking about African Americans, and do at least a check-in and have a conversation. I did this one talk with African American women who came in. It was a community outreach thing, and they said some of them had cancer, and they said, my doctor, I had cancer when I was 42. My doctor never told me that I should get it checked, or never, and that precipitates that anger and lack of trust, and it becomes that cycle. So I think, everyone, please make sure that your community knows that these women are at higher risk, and their cancers, it is important when we catch them earlier, because it is a life or death situation.
And then what happens is that young woman told somebody,
Yep.
And she told 4 or 5 people, and each of them told 4 or 5 people.
They're never going to get a mammogram.
That's exactly right. That's exactly right. And so we begin those stories. That's why that lived experience becomes so important. Those stories perpetuate themselves for decades, and in many instances, when they do find out, because they heard that and they didn't get their mammogram, etc., they find themselves at a stage where it's a little more negative outcomes. So I think that in whether we're talking breast cancer or any of the other types of cancers, it behooves us to be able to take that time to listen and understand, because people are influenced and impacted by their lived experiences, and that includes those environments that are sometimes barriers to their being able to get the resources that they need.
I think we are out of time. So again, thank you to everyone who called in, and a huge shout out to Dr. Bankston, Dr. Jackson. This was awesome, and I look forward to future sessions and collaborations, and we're going to save the world.
Absolutely.
Go.
Absolutely.
One person at a time.
That's right. That's right.